Good morning. Well, as people start trickling in, I'd like to welcome you to our inaugural Perinatal Mental Health Grand Round. My name is Penny Theodoro, and I work in the Child Health Advocacy Institute and lead our perinatal mental health work under the direction of Dr. Lee Beard. I also manage the Children's National Perinatal Mental Health Task Force, which is an interdisciplinary group of over 40 staff here at the hospital that come together to address the perinatal mental health concerns of our parent population. We meet on a monthly basis, and we're open to everybody. So if you are interested after this talk, please do reach out to me. On behalf of the task force, I am honored to introduce our speaker today, Dr. Amy Danielson. Dr. Danielson is the founder and director of the Women's Mental Health Program at MedStar Georgetown University Hospital. She's a clinical psychologist and associate professor of psychiatry and obstetrics and gynecology with a specialized exclusively in the field of perinatal mental health. Over the past 17 years, she has developed and implemented numerous clinical, academic, and research programs to respond to the unmet needs of women in Washington, D.C. In 2008, she founded the Women's Mental Health Program at MedStar Georgetown in response to the critical needs for specialized care in the region. Across MedStar, she leads efforts to train medical providers, residents, students, and nurses on screening for perinatal mood and anxiety disorders and has successfully implemented universal screening across multiple hospital settings. Dr. Danielson is an active member of several local community maternal mental health initiatives, each of which have enabled her to grow her capacity of primary providers across DC and serve as an advocate both for the awareness and increased quality to mental health care. It's in this capacity that I've been able to collaborate with Dr. Danielson. As an expert in the field, she speaks locally and nationally on topics related to maternal health and has been an invited speaker to On the Point with Tom Ashbrook from NPR, as well as contributing to stories in the Washington Post and Huffington Post. It is my distinct honor to welcome my colleague, Dr. Danielson, to the podium.
Thank you for having me. I'm honored and excited, and I could probably talk about this topic for the next 3 hours, so I'm going to try to keep myself on task. In fact, the way I will start keeping myself on task is I'm going to set an agenda so that I don't go on and on, because I can tend to do that when I start talking about this area. So we're going to start out talking about what PMADs are, a quick overview of what they are. Some of you may know that what PMADs are, some of you may not. We'll start there. We're going to spend a lot of time talking about why this topic matters, probably half our time today. And some of that is going to fold into the consequences of untreated mood and anxiety disorders in mothers. We'll talk a little bit about the normal experience, risk factors for PMADs, do a deeper dive into what the conditions look like themselves. A little bit on screening, because I feel like I would be preaching to the choir if I spent a lot of time talking about screening at children. So I am going to do a little talking about it, as well as how to talk to mothers. And then we'll talk a little bit about how we treat these conditions, as well as some of the local initiatives in and around DC and at Children's focused on screening and increasing access to treatment. All right, so let's jump in. So PMAD basically is the abbreviation for perinatal mood and anxiety disorders. And so we used to really talk about PPD, for postpartum depression. And what PMADs are, and in fact, I'm going to jump forward a few slides. There we go. So the perinatal period, if we sort of start with the kind of the basic block, is really defined as conception through the baby's first birthday. So what we're talking about here is roughly about, I don't know, a year and a half, a year and 10 months or so, where we're thinking about focusing on women in pregnancy and postpartum. And during that time, we see a increased likelihood, an increased prevalence of a number of different psychiatric disorders. And those are called the PMADs, perinatal mood and anxiety disorders. The mood disorders we're talking about are major depression and bipolar disorder. The anxiety disorders we're talking about are generalized anxiety, panic disorder, obsessive compulsive disorder, and post-traumatic stress disorder. We're also including in the PMADs postpartum psychosis. So we don't think of that as a common condition, but I will talk about it briefly today. So these, when we talk today, and I refer to things like disorders, conditions, or illnesses, this is what we're talking about. Go back up a minute. So I'm going to start with like our two sort of biggest statistics to kind of get us talking today. Mood anxiety disorders affect about, the latest statistics are about 1 in 5 perinatal women, so roughly 20%. If we move to a population, a higher risk population, and so we would be thinking about women of color, Black women, Latina women, documented and undocumented immigrant women, women with fewer social and economic resources, those, I would say, who are most disenfranchised in our society, we think it's 1 in 3 or 1 in 2, which is pretty staggering when you think about it. These illnesses are the #1 complication of pregnancy and childbirth, yet they're the least screened. So other complications such as gestational diabetes, which we have routine screening, routine universal screening, and PMADs are about twice as common as gestational diabetes. So these illnesses are biopsychosocial. So all of these disorders, conditions, are affected by multiple complex factors, biological factors like a woman's mental health history, her reproductive history. And so her mental health history may be, for example, a history of depression that she's experienced at other significant life transitions. Maybe her reproductive history, I often will talk about the experience of anxiety that a woman might have in pregnancy. If you think about a woman in her first pregnancy that was planned versus a woman that maybe is in her 5th pregnancy after 4 previous miscarriages. So when you start to think about that, how that reproductive history is going to impact her mood in pregnancy. Her general health, her responsiveness to hormonal changes, the estrogen cliff that women fall off of after they have their baby, and how she personally may respond to that change, as well as psychological factors like her personality, perfectionism, for example, something that we see quite a lot. There's not a lot of research about this, but women who have more perfectionistic personalities tend to have a difficult time, particularly during the postpartum period, where the babies don't necessarily, as I say, kind of get the memo on the plan that the mom may have after baby's born. The difficulties with the identity or the identity and role transition, unrealistic expectations for the transition for parenthood, which, despite social media, is still prevalent. I don't think anyone can really be prepared for the transition to motherhood, the transition to parenthood, how challenging it can be, and we'll talk more about that later. Social factors, a woman's history of trauma, and we might talk about farther-term trauma, like a history of childhood sexual trauma. We may also talk about, which we'll reference later as well, nearer-term trauma, like a traumatic childbirth experience. A woman who thought her own life or the life of her child was in danger during her childbirth experience. Social changes that happen, which is, I think one of the most significant aspects of the transition to motherhood and parenthood is the social changes, relationship changes, and of course the resources a woman has. And by those I might mean practical resources, financial resources, as well as social resources. So we can't really do justice to this topic without spending a moment to address maternal mortality in the U.S. And this is going to kind of come back to maternal mental health in a moment, so bear with me. In 2017, the CDC released a groundbreaking report about maternal mortality. And NPR and ProPublica released something called the Lost Mother Series. What these reports revealed was that the U.S. has the highest rate of deaths related to pregnancy and childbirth in the developed world. Half of the deaths are preventable, and victimizing women from a variety of races, backgrounds, educations, and income levels. About 700 women die from pregnancy and childbirth each year, and 50,000 suffer life-threatening conditions. This rate has tripled from 1993. You can see this graph here, how it just steadily inclines. This means that compared with their own mothers, American women today are 50% more likely to die in childbirth. And the risk is consistently 3 to 4 times higher for Black women than white women, irrespective of income and education. What they also found was that about half, maybe 60% of these deaths are preventable. So what I want you guys to begin to think about is the incredible time of vulnerability for new mothers for medical conditions, medical complications, as well as anxiety and depression complications in those first weeks and months after their babies are born. Here quickly is just an illustration of when these deaths happen. Half happen during pregnancy, half happen after delivery. And the thing that to me is most interesting about this is that about 70% of these deaths occur outside the window when a woman is hospitalized for having her baby. Most of these deaths occur when she's either pregnant or back home after her baby's born. The leading causes of death, the physical causes, are the ones that are most of the reports and the media attention that this has garnered are really focused on the physical causes. Infection, hemorrhage, embolism, hypertensive disorders, cardiovascular disorders. The rates of maternal death secondary to self-harm have been omitted from published rates of maternal mortality. So we're talking about both suicide and overdose. We think from more research that's been going on over the last 5 years, and most of this research is happening on the state level in states that have good maternal mortality review committees where they have actually pretty good data that they can begin to look at this, that we think the peak incidence of self-harm is at the end of that, nearing the end of that first postpartum year. There was an excellent study in Colorado that looked at suicide and overdose, and they found that the combination of deaths due to suicide and overdose was the leading cause of pregnancy-related death. And this actually parallels research outside of the U.S. where they keep much more copious records of how, when, and why women are dying, people are dying, that has found that suicide and overdose, self-harm, is the leading cause of pregnancy-related death. So in this case, 100% of self-harm deaths are preventable. So if we think that suicide is one of the leading causes of postpartum death, this is one of the reasons we should care. This is a frequently cited and staggering figure, in my opinion, that reflects the sudden spike in frequency of admissions to psychiatric hospitals in those first months. Again, that sort of first, we'll say, 3 to 6 months after a woman delivers a baby. And one of the things that we know about postpartum suicide is that women tend to use more lethal means during this time frame. And so the thing that's important to realize about this is that we're not exactly sure why, but some of you may know this, that there's a gender difference with respect to suicide, that females have higher rates of suicide attempts, whereas males have higher rates of suicide completion. And this is across the lifespan. And so we think that this is because men tend to choose more lethal means, things like guns, hanging, jumping off buildings, whereas women tend to use overdose with pills. This appears to look different for women in the postpartum period, and we're not exactly sure why, but that women are using more lethal means when they attempt suicide, and so the opportunity to intervene and to save women is much less. So again, what I'm trying to characterize here is that this immediate postpartum period is really a time of intense vulnerability for women, and it's actually been given a name called the fourth trimester. That's a name that it's been this sort of, we would say, the first 3 to 4 months after a woman has a baby, which we'll talk more about in a little bit. So these sobering statistics that we've talked about really reflect the true crisis in maternity care in this country, and they're really embodied in the experience of new mothers who feel invisible to the healthcare system after their babies are born. So here was a quote from a woman, or a quote from a talk that I love. The baby is the candy and the mother is the wrapper. And once the candy is out of the wrapper is cast aside. Depression in particular in pregnancy is associated with considerable morbidity and mortality for both the mother and the fetus. When we talk about the mother for a moment, we see women who have depression, untreated depression in pregnancy, be less compliant with their prenatal care. They're more likely to self-medicate, manage their depression, their anxiety, their insomnia with things like alcohol, tobacco, illicit drugs. And as cannabis products, one of the things I've noticed quite a bit in the last probably 2 or 3 years is that as cannabis products move from illicit to licit, we're seeing a lot more women self-medicate, anxiety in pregnancy, insomnia in pregnancy, nausea in pregnancy, aches and pains in pregnancy with an assortment of cannabis products, which to date, there's not enough research for us to have a good handle on the impact to her fetus of using those products, but the data that's come in so far points to the fact of what we would suspect is that it's not great. And a lot of these women will think of this as a natural alternative to something like a medication that might be prescribed for anxiety or depression during the pregnancy. We see women who are depressed in pregnancy bond less well with their babies. And for a lot of these women, there's something to me that is really both important and necessary for the sort of survival and evolution of our species, for a mother to be thinking proactively and protectively about her baby before her baby is born. It's like essential to the kind of bond and the relationship with her child, kind of getting off the ground in a healthy way. And so these women often seem very disconnected from their pregnancies, and many times are shell-shocked after their babies are born, which again we'll kind of talk about later, the impacts of that. Also, we want to think about the impact on the broader family. Most pregnancies aren't first pregnancies. So we're not just thinking about the baby in her belly, we're thinking about her 2-year-old, her 4-year-old, her 6-year-old, and the impact of the depression on that relationship in that child. There's a greater risk, of course, of self-harm and suicide, and then, of course, postpartum depression, so that she kind of, she sort of is starting off wobbly before the baby even gets here. Then if we move over to the baby, the fetus, really every negative fetal and obstetrical outcome that we have, a study has associated with severe untreated depression in pregnancy. So preterm labor, prematurity, low birth weight, babies born small, in a stress state, with elevated cortisol, low APGAR scores, neonatal complications, NICU admission. A few studies suggesting that untreated severe depression may be predictive of fetal demise. Again, in part related to all the things that go with the untreated depression. If we walk it out, so after baby's born, now we're thinking about depression is still untreated, baby is now here, and we see depressed mothers have considerable problems with breastfeeding. They're more likely to feel negative about their breastfeeding experience. They're more likely to give up early. They're more likely to have problems with breastfeeding. Depressed mothers are less emotionally responsive. Their bandwidth is saturated, really, and that they have less, they're less emotionally available for their babies and for their kids. They're modeling more negative mood. There's less consistency with their discipline, the way they're handling the problems in their 2- and their 4-year-olds, and the inability to assist with emotional regulation. And emotional regulation, co-regulation, and the way mothers assist babies with regulating their emotions is one of the single most important tasks in the mother-child dyad. So, for example, if a mom is up in the middle of the night with a baby who's not sleeping, and she is overwhelmed, she is anxious, she is depressed, she has a baby that's not asleep, that's up in the middle of the night, and this mother has trouble coping with the demands of that. And so this mother, you might imagine, sits down in a rocking chair to try to rock that baby to sleep, and she is angry about the baby, She may be angry at her circumstances. She may be feeling regretful over having had a baby, and that imagine this mother kind of rocking in the rocking chair. And I'm giving you an example of a story that a patient shared with me, and actually it's an example in some ways that I can relate to when I think about my own experience with my kids when they were little, when I was just merely just tired and sort of frustrated with one of my daughters being a baby and not wanting to sleep in the middle of the night. This notion that, and how that impacts a child, how that impacts an ability to soothe a child and be able to recognize what a child needs, but then also how that impacts a person's body and how a child responds to that, and that they may be sort of fussy or intense themselves, which then gives back to the mother. And so this is sort of this dance that isn't optimal, for lack of a better way of putting it, that can really impact not just a mother's feeling about her baby and her attachment to her baby, but also a mother's feelings about herself as a mother, her capabilities as a mother, etc. The impact, when we think about the impact of untreated depression on her child, we see the science shows us behavioral problems, cognitive problems, impaired social development, problems with the attachment, significantly worse school outcomes. I mean, it really goes on and on. That untreated depression in a mother is a problem for both mother and child, sort of. I am going to skip this. I may show it at the end if I have time, but unfortunately, I can already start to feel myself. So these were just titles of papers, working papers from Harvard University Center on the Developing Child. The foundations of lifelong health are built in early childhood. Persistent fear and anxiety can affect young children's learning and development. Children's emotional development is built into the architecture of their brains. Maternal depression can undermine the development of young children. That's it. One more. Establishing a level foundation for life, mental health begins in early childhood. So science tells us that the foundations of sound mental health are built in early life. And this is something that I want to keep going back to over the course of our time together today. I also want to mention maternal depression, and we're going to be beginning to learn more and more about this. That maternal depression, a mom who's depressed, that's the number one predictor of the dad becoming depressed as well. We think that about 1 in 10 fathers develop maternal depression. And the way their depression looks is actually a little bit different, that we see prominent anxiety, anger, frustration, stern, kind of overly corrective, overly authoritarian discipline style. And what I see actually over and over again in my practice is a tendency for fathers to pour themselves into their work, almost as a form of avoidance of the stress of what's going on at home. Depressed parents are also more likely to use the healthcare system and the ER, to overuse the healthcare system, and they're less likely to adhere to safety guidelines like safe sleep, car seat usage, and that, I see this actually a lot in my practice also, that women and men, parents essentially who are depressed, are much less likely to be, I think, thoughtful about decisions about where and how their baby sleeps. In part, I think, reflecting a desperation on their part to get the sleep that they need. Some of the untold costs, of course, are the impacts on the relationship with each other and the relationship with their children, and not having other children. I just actually spent a weekend with a friend this last weekend from out of town, and she reminded me, I asked her about how her brother was doing, and she said, he's doing great. And I said, how's the family? And she said, they're doing great. They had one child, and their one child is 8 years old. And I was asking them about that. I said, did they ever think about having any more children? And they said no, because his wife had severe postpartum depression she was hospitalized for, and that was the game changer. They had planned on having 3 and 4 children. She comes from a large family, lots of kids. My friend's sister-in-law, as my friend put it, was one and done. That was enough for her. And this is something we see quite often. So the huge study that came out, big, groundbreaking study that came out at the beginning of this year, this economic analysis put together by Mathematica that estimated the economic cost of these disorders. When they followed mother-child pairs from pregnancy through 5 years postpartum, the estimated costs are $14.2 billion for birth in 2017 alone, or an average of $32,000 for every mother-child pair. And the kind of common costly components are things like absenteeism at work, something called presenteeism, which is you're at work but you're making lots of mistakes, unemployment, maternal health expenditures, preterm birth, etc. So to kind of sum this section up before we dive into the conditions themselves, again, this is the most common complication of pregnancy. What I haven't mentioned yet, that I'll talk more about later on, is that one of the reasons that I've loved doing this work, this has been work that I've been doing for over 20 years. One of the things that inspires me and motivates me to keep doing this work is that these illnesses are incredibly treatable. With the right treatment, women who will describe themselves as sick as they've ever been in their life, as unrecognizable to themselves as they've ever been in their life. These women, within 3, 4, 5 months, many of them feel back to themselves or better. So these conditions are highly treatable. It also presents this wonderful opportunity to help women that have a prior undiagnosed mental illness who are at continued risk for mental illness. we think about 20% of women that are identified as having postpartum depression had depression before they even got pregnant. They didn't know it, or they knew it and they didn't know what to do about it. They didn't recognize it in themselves. And so this becomes this window of time when women are connected and engaged with their obstetrical care, or when they're connected and engaged with their pediatric care after their child is born. Well, we have the opportunity to identify women that need help and offer it. I think the rest of the points kind of summarize and speak for themselves. All right. So let's do some talking about the conditions themselves. And before we do, I wanted to spend a minute. This actually there was an article in the New York Times this week. And I feel like before we talk about the conditions, it's really, to me, important to acknowledge the ordinary and even sometimes extraordinary challenge that the healthy transition to parenthood presents. And this was from the New York Times. It was this amazing piece. I actually encourage you to read it. I think anyone who's a parent or wants to be a parent can relate to it. It's on the tension between the real and idealized motherhood. And it provides this amazing historical perspective. This is not a new thing, basically, is what they were saying. This pressure that we all have to or feel to experience parenthood as delightful, when in reality, most find it difficult and also delightful, but difficult. And this has been a norm for 200 years. And so this quote I love from the article from Lula Kendall Rogers back in 1864, who said, "I fear I am not very charitable towards babies, as I find myself at such times wishing for a, quote, lodge in some vast wilderness where the cry of babies might never reach me more." So this is a healthy mom, I think, courageously commenting on how hard early new parenthood is. And I love the image as well, with the SOS on the laundry hanging behind her. I don't know if you guys caught that. Okay. So what else let's try to characterize the normal transition to motherhood for a moment before we talk about what is non-normative. It's generally thought baby blues. So I should actually back up and say the sort of confusing of baby blues and postpartum depression is actually a pet peeve I have. So if you get nothing away from this talk today for being able to differentiate those things, I will be very happy. Baby blues is the normal experience. It's really benign. It's transitory. It's an experience that occurs within the first 10 days to 2 weeks postpartum, tends to begin around day 3 or 4, peak around day 4 or 5, and the kind of hallmark experience is weeping, crying for no reason, or maybe crying because you feel sad, maybe you miss your old life, maybe you feel envious for your partner who kind of gets to go back to work and resume some normalcy. Maybe you're irritable. Maybe there's this lack of affection where you sort of feel like you want to be in a bubble and not have anyone come near you. There's also increased feelings of dependency during this time and a sense of unreality. By that, I'm not talking about the psychotic variety. I'm talking about this sort of what happened to my life feeling that we've all had after we've undergone a big life change. That the data shows that up to 85% of new moms experience this, and my joke on this is the other 15% were lying, that this is the universal experience. And most women recover from this experience within about 2 to 3 weeks. I would say at the very outset, 3 weeks. And what they benefit from during this time is other mothers, support, help, the normalization of these experiences, instruction on newborn care, someone that can kind of be beside them, helping them with the baby's first bath, those types of things. Someone who can kind of get up with the baby at night and assist them after the baby's been fed but the baby won't go back to sleep, these types of things. It's generally thought that this experience is related to the hormonal and physiologic changes that occur after delivery. I'm going to come back to this in a little bit. So I want to contrast this with postpartum depression. What does it look like? So postpartum depression, we think it's about 1 in 7 women develop postpartum depression. It usually begins within about 1 to 6 months after a woman has a baby, and it can look two different ways. Its onset can kind of grow, so to speak, out of the baby blues. And in this case, women will say, from the moment my baby was born, I never felt right. I never felt like myself. Something was different. Or women can have an initial period of well-being, and maybe it feels as though they thought it was going to feel after their babies were born for, 1, 2, 3 months, and then they start to either develop symptoms gradually or in a marked, kind of abrupt way. So to try to bring it to life for you, depressed mothers can often, obviously, feel depressed. Some will describe it as feeling sad or mournful, a sense of grieving their pre-baby life, a longing in some ways for their pre-baby life. But I should say, as many mothers also experience anxiety, chronic worry. The way they present is almost brittle, tense, anxious, irritable, kind of unable to cope. They may present as angry. They may come in and saying, I'm having like fits of rage that isn't like normal for me. I've had 2 women in my career who've come in, and their main reason for coming in is that they want support during a process of divorcing their husband. And they are new mothers. And in both cases, it was incredible. They had no prior real marital dysfunction or dissatisfaction to report, but within a month of their first baby being born, they were so angry at their husband and felt essentially like the marriage wasn't something they wanted to continue. And sure enough, what was happening is that these were really horribly depressed women, and the marriages were not perfect. They needed a little bit of work in tending to as well, but really the depression needed to be treated. Women will describe feeling lonely, hopeless, guilty, and worthless. And one of the things I want you all to think about is what I call the double whammy, which is no one ever wants to feel depressed. But one of the worst times to feel depressed would be at a time where you expected to feel happy, satisfied, fulfilled, a sense of meaning and purpose that many women expect to feel after having their first baby. And so it's this horrible double whammy. You're forming your identity as a mother at a time when you're depressed. Depressed mothers think often we have really pervasive evidence of pervasive unrealistic expectations for new motherhood and the baby. A lot of women feel like they'll instantly love their baby, that it's natural or instinctual, that their baby will basically be able to be, will either be sleeping, eating, or adorable, and that's not often what it looks like, especially in the beginning. The worry wheel, preoccupation with a baby's safety and vulnerability, a diminished ability to think clearly. I'll have women that will say, I literally read the same email or the same article 15 times, I still can't tell you what it says. Ego dystonic thoughts of harming the baby. And that's the clinical way of putting it. We call these scary thoughts. They're images, scary thoughts are images that pop into a woman's mind of ways that her baby could get hurt on her watch. And ego dystonic means they're really scary because they occur in the context of a woman wanting to keep her baby safe. Thoughts of death, her own or her child. Depressed mothers are generally pretty shut down. They're avoidant of sex and affection. They're crying a lot. They may be fighting or strained with their partner, withdrawing from friends and family. They may not be bonding well with their babies. They often are not bonding well with their babies. You all may see this in a pediatric setting, sort of frantic efforts to get control, frantic calls to the pediatrician about something that may seem, from a pediatrician's perspective, as really an ordinary challenge of the first month or 2 of parenthood. These will be women that are trying to sleep train their babies when their babies are 4 weeks old, something that's not appropriate, but something that they're trying to do to get some control over their sleep. Again, they're having sleep problems. They can't sleep when the baby sleeps. And so this is something, I would say all new mothers have sleep problems because everybody's tired. They all need more of it. But the problem that depressed mothers have is that they can't sleep often when the baby's sleeping. And many of them are having breastfeeding difficulties. The other postpartum problem that I want to talk about is anxiety because it's often under-recognized. It's often hidden. It really hasn't been well researched. I would say the last 5 years we've seen more research in this area, and we're talking about generalized anxiety disorder, We're also talking, I'm not going to go in great detail, but we're also talking about obsessive compulsive disorder, panic disorder, and PTSD. These women, and that often goes hand in hand with depression. I would say about half of the women I see for postpartum depression also have an additional diagnosis of generalized anxiety disorder. So these women will come in and say, something's wrong with me. I'm not depressed. I don't know what's wrong with me, but I don't have postpartum depression, but I'm not right, is how they'll describe it. They're on edge. They're overwhelmed. They feel like they can't quiet their mind. There was this woman that I always think of when I'm talking about postpartum anxiety who came into my office the very first day. She sat down in the chair, and she appeared to be vibrating in her own skin. She just was like restless and jittery, and she looked me dead in the eye and said, I feel like I have bees in my body. And I thought, what a horrible feeling, but also what an incredible way to capture what this experience was. So how much is too much anxiety? So these are actual pictures that I took of labels on a pack and play. This one's my favorite. This is a label on a bucket. These are basically, essentially labels, warnings for parents about how their babies could die if they're not careful. So we live in a time where parents feel afraid. They feel a sense that many of them, that they need to be extraordinarily cautious. Controversial policy directives, such as the most recent modification that the AAP has given to recommend that babies room in with parents until the age of 1. I think in part, not intentionally so, but contribute to the sense that we have to be hyper-vigilant so our babies don't die. So this notion about how much worry and hypervigilance is normal for a new parent, even necessary for the survival of our species, versus how much isn't, is something that we grapple with as we work with modern parents every day. So postpartum anxiety disorder, or postpartum psychosis, is, I'm going to only spend a minute on it because I feel like I will never talk on this topic without touching on it. It's very rare. About 2 in 1,000 women will develop postpartum psychosis. It is the most severe form of postpartum psychiatric illness. It often presents within the first 2 weeks. It tends to present, I should say, within the first 2 weeks, but often within the first 72 hours after a woman gives birth. The biggest risk factor for postpartum psychosis is having a prior history of bipolar disorder. So these would be women, if you have a patient or a friend or a loved one who has bipolar disorder and they're planning to become pregnant, this would be a situation where consulting with a reproductive mental health professional would be a great idea prior to pregnancy. Because coming up with a plan to stay well both during pregnancy and the postpartum period is really important. There's around a 30 to 50% chance of postpartum psychosis in a woman who has bipolar disorder that is untreated after she has her baby. So these are the lion's share of women developing psychosis. The symptoms, thought disorganization, delusions and hallucinations, and they tend to be focused on the infant. The delusion that the infant is dead or defective, may not belong to them, that the infant is dangerous to the other children in the family, to the world, the infant is possessed, that the symptoms can come and go. We also see oftentimes sleeplessness accompany that. So these may be women that 2, 3, 4 nights have 0 winks of sleep. Again, think about how tired a new mom is. So that periods of sleeplessness, guilt, worthlessness, and I should say that the most important symptom to be aware of is that these symptoms occur with a true absence of insight. So these moms don't know this is happening, which relies on folks like you in this room who are either mothers yourself, know mothers, love mothers, treat mothers, understanding what this is and what this looks like. Again, one of the things that's important is this is a psychiatric emergency when it presents. About 5% of women with postpartum psychosis will commit suicide. 4% will commit infanticide. These are low numbers, but a very, very dangerous condition. So this is an immediate psychiatric hospitalization, and I should say that these women, after they get adequate treatment, they get better. They get better pretty quickly. Okay, so I'm running low on time. But again, I probably needed 3 hours to do this. So I'm going to kind of scoot through a couple of these slides quicker than I'd intended. Women of color, there's a paradox with postpartum depression, and that is that women of color living on low income are the most likely to suffer from postpartum depression and the least likely to receive proper care. About twice as many mothers of color will develop postpartum depression, and factors like poverty, racism, gender discrimination, increased exposure to violence, prior trauma are responsible for this increased risk. These women are screened less, and they're less likely to get services that they need for a lot of different reasons. Some of it has to do with access to health care in general, feeling disconnected from their providers, in part because maybe they don't have a culturally or linguistically appropriate provider available to them. They may have a lack of access to providers of color. And also, if there is someone available to them, they're less likely to seek treatment due to cultural barriers and stigma. A lot of these risk factors I've already talked about. Family history, personal history, being younger in age, an unplanned pregnancy, lack of social support, the way in which we're now having families which are often disconnected from extended families, that we're not surrounded by aunts, grandmothers, cousins who can literally share the list of caring for a newborn. A history of trauma, relationship difficulties, a relationship being on the fault line. Unfortunately, about half the pregnancies in this country are unplanned. Many pregnancies are unplanned, and even those that are planned occur in the context of an unstable, unhealthy, toxic relationship. Big risk factor. Prior history of pregnancy loss or termination, as well as infertility treatment. And the recent big life change, which this is a tricky one, because generally, what are people doing when they're pregnant and when they're expecting? They're trying to find a place to live that can accommodate it. They may be trying to find a job that can pay them more, that has benefits, that can give them more time off after they have their work. They may be taking on a second job so they can afford this little bugger. And all of these things are sort of baked in the perinatal transition. Having a fussy baby. Mothers in the NICU, we think about 30% of mothers in the NICU meet criteria for post-traumatic stress disorder. Perfectionism, as I mentioned, suddenly discontinuing medication and problems breastfeeding. So basically, this is the bottom line. Anyone who has a baby is at risk. And so systematic screening and referral to routine medical care during routine medical care is one strategy to decrease these disparities that we're talking about. And pediatric primary care is a really critical setting for this, and it's happening all across DC and at children. This is the tool. How many of you are familiar with the Edinburgh postnatal depression scale? Okay, all right, good, that's great. This is our gold standard. It is not perfect, but it's a quick 10-item questionnaire, easy to start, or you reverse code these asterisk items. It detects anxiety well. There's a couple of items that specifically ask for anxiety. And item 10 is a question that asks about suicidality. So if a woman scores anything other than 0 here, or any 10 or greater on the entire scale, she would be thought of as at risk for having depression and needing to be referred to a mental health provider. Okay, so this doesn't diagnose depression. It merely says that she's at risk. I'm trying to think if there's anything else I want to say about this before I move on. I think that's about it. I should also say that it's validated for the entire perinatal population. So it's a postnatal depression scale. It's been validated in pregnancy, so we use it now. We can use it at multiple points in pregnancy. We use it at Georgetown, where I work, in the hospital after a woman gives birth. Within 24 hours of giving birth, she's given the Edinburgh. We use it in the pediatric setting, at multiple points in the pediatric setting, to try to catch women that are developing symptoms at various points. It's also recently been validated for use with fathers. Validated in Spanish, all the major European languages, and it's in literally dozens of different languages. Okay, when we think about how to talk to a mom, I find for folks that basically are working with mothers in various capacities, like you all in this room, that it's just sort of helpful to have, I would say, questions that could just help you connect with a mom and better understand her experience. And so these would be these questions. So this would be either in addition to screening or in lieu of screening if you didn't have screening in place, but you had a sense that you wanted to try to draw out a mom that you were suspecting was having a hard time. How are you feeling about being a new mother? How are you coping with the additional stress of a new baby? I like that one a lot because it presumes there's stress. Because generally, if you ask a new mom, how is it going? What are they going to say? They're going to say, wonderful, it's great, or I'm tired. And then that might be kind of all you get. How are you coping with the additional stress? Are you able to sleep when the baby's sleeping? Do you find yourself crying a lot? Have you had any thoughts that are scaring you? I ask every mother I work with this very question. Are you having any thoughts that scare you? And when we're talking to these moms, we want to normalize the experience she's having. We want to validate and we want to offer hope. And this is sort of this notion that in order for her to build the house, in order for her to take care of her baby, that she needs to take care of herself. She's the foundation of the whole thing working. There are a lot of barriers to seeking treatment, and some of them are psychological, things like stigma, that it's a sign of weakness to get treatment, denial, having bad experiences with mental health professionals in the past, fear of being labeled, fear of losing one's children, having them taken away by CPS. And then there's the practical ones that we've already talked about as well. And one of the big ones in our town is the financial commitment. There are very few providers who accept private and public insurance. This is a huge, huge problem. Penny and I were just talking about this before my talk today. So the good news, we're going to end on the good news. They are treatable. And this is a brilliant document that I did not put together, a brilliant slide I did not put together, that talks about this path to wellness that starts with simple, but not so simple for a new mommy, simple changes at home. Many women that come to see me, it might be a 4 o'clock appointment in the afternoon, and they haven't had a thing to eat, they haven't had any water, they haven't showered yet, and they had terrible sleep the night before. These women are suffering from profound self-neglect. So this is where we start. It seems really simple, but we start basic, and they need a lot of coaching to be able to get these things done when they have a small baby to take care of or small babies to take care of. So this starts with things that are kind of easier, cheaper, moving towards more involved, more expensive. So home visiting, where we have women who have supportive visits, practical visits to help with the baby, coming to them in their home. Social support, psychoeducation groups, support groups for other mothers, groups like that are supported through Postpartum Support International. Other mothers providing support for mothers with postpartum depression, and then of course psychotherapy and medication. So we can do a lot in therapy, and I'm just going to kind of hold this slide up to sort of symbolize what it is. Because I want to talk sort of generally, I'm running out of time, that psychotherapy in a nutshell works. There's a lot of good medical meta-analysis reviews. And this is, and essentially most of the psychotherapy that we think of as empirically supported therapy for women with PMADs would be time-limited therapy that's problem-focused. So we're not thinking about the therapy that you may see on TV that's psychoanalytic, laying on a couch, talking about things that happened in your childhood. That's the psychotherapy stereotype, and actually it can be very beneficial. It's wonderful in its own right, but in terms of treating these disorders, these are brief, time-limited, very problem-focused therapies like interpersonal therapy and cognitive behavioral therapy. One of the things when we think about treating in the postpartum period, the treatments address both biological and psychosocial factors. SSRIs, medicines like Prozac, Lexapro, Zoloft, things like that are our first-line therapies because they work and they're well tolerated. I would say that when we think about treatment of depression and pregnancy, it's a little bit different. Generally, we think that women that have the mild to moderate symptoms in pregnancy, that they tend to prefer non-medication interventions, and that's what we tend to recommend for women in that mild to moderate range. If they're in the moderate to severe range, where we're talking about disabling or serious depression, medication is thought of as first line to treat depression and anxiety in pregnancy. And generally, the ideal scenario is this combination of antidepressant medication and psychotherapy. That is the ideal scenario, but either one is better than nothing. So when the decision that psychiatrists make sort of are complex, and a whole talk could exist on this alone. It's weighing the risks and benefits. And the risk, we're talking about when a psychiatrist thinks about a woman here is depressed in pregnancy, we're going to want to weigh the risks of untreated depression, the risk, for example, of relapse of depression if she is treated before her pregnancy but wants to come off her medication in pregnancy, the effects of the psychiatric illness on the fetus, the teratogenicity of psychotropic medication, neonatal toxicity or withdrawal syndrome, and overall the limits of reproductive safety data for medication. These are the things that a psychiatrist is weighing when they counsel women and they meet with them and make recommendations for during pregnancy. There is no such thing as zero risk. I think everyone in this room would agree that zero medication, zero illness would be the ideal scenario. But outside of that, there's no such thing as zero risk, and there isn't really a specific algorithm. But the idea here is that we want to balance two risks, weighing the risk of untreated illness against the risk of pharmacologic intervention. So I'm going to end today with just laying out a few resources so that all of you know where to send women who need help. And actually, I'm happy to share all of these slides, or just even these last 6 slides, so that you all have them handy. These are resources for insured patients, Women's Mental Health Program at Georgetown. We accept about 30 insurances, as well as both private and public. The 5-trimester clinic at GW, DC residents with Medicaid, Medicare. Mary Center has an amazing maternal mental health program. Washington Hospital Center. I've been involved with training all of the mental health professionals at Trinity Square so that they have an increased understanding of these conditions and how to treat them. These are some wonderful resources, and they're here and they're on DC Health Check. This is a toolkit, everything I just described to you in a nutshell, including a screening program, a crisis action plan, language for how to describe a positive screen is all included in that kit, as well as this planning guide for those kind of mother wellness pieces that we talked about earlier, planning for that could be used with a pediatrician, with her internal medicine doctor to plan for health behaviors. DC MAP, a mental health access line for pediatricians, which I'm sure most of you all are familiar with. I'm happy to talk about that more at the end. Postpartum Support International. We have a DC chapter, a Virginia chapter, and a Maryland chapter. If you had a mother in front of you, whether it was someone in your office or someone at home, and you were worried about her and you wanted to get her connected with help, if you call the phone numbers for these women that basically lead these efforts in each of these regions, they will not stop until that woman is with a provider that she can see. So they're incredible human beings. This relates to what Penny was talking about. Children is a leader in DC, and one of the things that has been incredible is the Perinatal Mental Health Task Force that has been functioning for the past 2 years, that has 45 members, 11 disciplines and departments, and it's just developing best practices for detecting PMAS, for screening at children. And it's actually an example for other hospitals in the city. Here's a way to get involved. Penny's right here, and Penny would happily talk to you more about getting involved if you wanted to join the task force. And so I'm just going to end here. These are my 3 beauties. And, thank you all really for the opportunity to talk about this. This is a field that I have been fascinated with before, during, and after having my own perinatal transition with these 3 girls, and I relish the opportunity to talk about it. Thank you so much. So not many time for questions, but if any of you have questions, I'm happy to take a few questions now and then stay later for more. Yes.
Thank you. That was a great talk. The obvious question is that in Europe, they have a very different system where they all have the public health nurses coming in and providing postnatal care. They'll have a single payer assistance so that health care is provided to everyone. Have there been studies looking at both the prevalence of these problems and the outcomes in European countries versus the States?
Yes, there have been lots of studies, and based on my knowledge of the data, that the prevalence of these conditions is no less in other countries and other cultures. The access to the awareness and the access to care and treatment and support is far greater. But to my knowledge, the prevalence of the condition is not less. So in terms of from like a public health standpoint, you know, do these things happen less often in communities and in countries where there's more support baked in? That doesn't appear to be the case. But what we do see is that women that develop these conditions can often get the help they need, and in many cases, that help is integrated into their OB care. And so, as you said, they may have access to a therapist. They may have access to a care coordinator who will facilitate connection with a outpatient mental health practice. It might facilitate care with a mother-baby hospital, which exists have existed for decades outside of the U.S., where there are actual, I hate to call them psychiatric hospitals, but essentially that's what they are. They're places where women who have mental health conditions can get the treatment they need with their baby. So they get support for the relationship as well. We are beginning to have more of these available in the U.S. The first one was developed in the last, I would say, 5 to 7 years at UNC Chapel Hill. But there have been places in the UK, places in treatment facilities in Australia that have been around for 20 years doing this work. So we're definitely behind the curveball here and trying to learn from our international partners. Yeah. So another question. From there? No? Yeah? Okay. Yeah, that was it. Hi.
Thank you so much for being here. Has there been any research done on the difference between first child and subsequent children in the rates and, I guess, prevalence of these psychiatric diagnoses?
Yeah, there has been, actually. There's not a ton of research in this area, but it's interesting because if a woman has a postpartum depression with her first baby, her odds of having postpartum depression with the subsequent babies are 2 or 3 times greater having had postpartum depression with her first, if that depression was remains untreated. And so one of the things that people will push back with these, when you're talking about this, is a little pushback, and they'll say these conditions remit on their own. And there's mixed data about this. But what the data shows is if they do remit on their own, they may remit on their own at 2 years-ish, 18 months, 2 years, 2.5 years. And what is happening at that time for many women? They're having their next baby. And so there is this layering effect that we often see. And in fact, there was a woman I just evaluated in my office last week who just had her 3rd child. She has been unwell and suffering for probably 5 years. And it just got to the point where it's unsustainable now for her, that she has been depressed since her first baby was born. Now, having said that, what we also see is just because you don't have a perinatal mood or anxiety disorder after your first, women can have it after their subsequent pregnancies, not having had any problems after the first. We don't know why that is. Again, there's a perfect storm here. Just having had the baby is only part of the story. All the other factors, the social factors, the resources, what the birth was like, what her recovery is like, as well as the additional burden of we're not just talking about an infant, we're talking about an infant and a toddler, and for many mothers, the toddler's a lot harder. So second or third time around can pose an additional risk. Good question. Any other? Oh, yeah, yes. That's a really good question. So I'm not sure if you could hear it over there, but she's asking, outside of the screening questionnaire, is there anything that folks who are working in a pediatric environment at these 2, 4, 6, 9-month well checks that you can be kind of looking for? And someone introduced me to a term a couple of weeks ago, and I love it, and they called it the stomach silence. And when you are with a woman and you have an instinct, something kind of in you says, there's something not right here, that you are actually picking up on something that doesn't feel right. It may be her eye contact with you. It may be that she appears disconnected from a baby. In fact, there's a woman I think about who the first time she came to my office, she had a very small office, but she somehow managed to park a stroller in kind of the corner of the office, and then moved over and sat down in the chair next to where my desk was. And we had an entire 50-minute interview with a baby who was about 6 months in the stroller. The baby was cooing, reaching, trying to engage these voices that the baby heard in the room. And the mother, it was as though the baby wasn't there. And so that's one of the things that I will go to and some of this I think is sort of, it's sort of nonverbal and instinctive. But I would also say that those questions about how to talk to a mom, some of those can just invite her to talk about this. How has this been going? This is stressful. How has this been going for you? To try to draw her out. Because one of the things we see, and which is why your question's so perceptive, is that when we give the Edinburgh, we have a project where we're screening at Washington Hospital Center, and so many of those screens are coming back all good. And we know these moms are suffering. They're scared to report their symptoms, or they don't recognize what they're experiencing as symptoms. And so I think these conversations and these moments are priceless to be able to try to gauge what's going on. Well, I don't want to keep you all too late. So thank you so much.